thrilled today to have two experts share their approach to controlled substance prescribing. And I'm just really looking forward to having them walk us through a case-based approach. We have speaking with us today, Dr. Elizabeth Abbs, in addition to being my addiction medicine co-fellow, is a staff physician at Tom Waddell, where she practices primary care, internal medicine, as well as addiction medicine, and led a really phenomenal quality improvement effort across the San Francisco Health Network around providing providers with an organized framework with which to approach controlled substance prescribing. So really thrilled to have her here today. And Dr. Stephanie Clavijo, who many of you know, beloved addiction medicine fellow, who is in Thursday afternoon 486 HIV clinic. And we're thrilled to have her co-present with Dr. Abbs. So I'll turn it over to them. They've shared that please feel free to put questions in the Q&A section, and I will interrupt them as we're able to with time. And if anyone has questions in person, please again raise your hand, and we can pause amidst the talk and hopefully have a minute or two afterward. Without further ado, yeah.
All right. Good morning, everyone. I'm Elizabeth, and this is Stephanie, and we're so happy to be here today. So we're going to just quickly give you a bit of a roadmap of the change of practice that many of you have been privy to in Ward 86 and doing primary care HIV work for many years. I'll introduce to you this tool that you may or may not wish to use, but a helpful guide to help you ensure that you have something to look at when you're managing some of these gray zones with controlled medications. We'll pass out some modified controlled medication agreements and patient-facing documents that we've done the DPH that we invite you to use at Ward 86 if you find them helpful. And then we'll get into some juicy cases. Our main goals today are to help support you and give an overview of when to say no, how to say no to a patient who's asking for a new full agonist opioid start, managing those tricky, quote unquote, stable inherited patients, what to do when you feel like someone's risks are starting to outweigh their benefits of continuing on that prescription, and then when to stop or taper after an overdose. Feel free to speak up and join us in a dialogue whenever you have a question. So some background and conceptual work. This we know is important because we know here in San Francisco that we have a legacy of a lot of controlled prescriptions. Tom Waddell, where I practice, and Ward 86, where many of you practice, are some of the main players here in giving a lot of opioids as well as a good amount of opioid and benzo prescriptions. So that we know that they're common across the network. And for those of you who have the honor of writing those scripts every month, you know that it can contribute to a good amount of burnout. And we also know that tapering can be unsafe and cause more harm or get in the way of someone's continuity and care. So it's not so simple. Today, we're hoping to give you some tools to help share the burden. This is sort of a question to the audience. How do you feel when you're seeing a patient who has a controlled medication that you need to fill, and you know that they are potentially at risk for misuse or potential harm? Right before you go into the room, seeing their name on your template, what's that like? Excitement? Ease? When we asked Tom Waddell providers this in the past, we gave them sticky notes and a pen, and they drew pictures of steam coming out of their ears, their heads exploding, this idea of carrying the burden of all of their own worries and the fear, the sense of blame. One person literally drew a picture of them running away from the clinic. Does that seem consistent with some of your experiences? All right, so we know that there has been a pendulum practice. Many of you have seen it in action or the sequelae of it in practice. And so in the 90s and early 2000s, opioids were used for chronic pain, a big push from Big Pharma. And these were not prescriptions that were started out of malice, but an attempt to help our patients who were dealing with many vulnerable disease states and psychosocial components of their care, especially for folks living with HIV who we didn't know their life expectancy at that time. Of course, things snowballed and pain became a vital sign. And then we started to see at times that people were developing misuse and opioid use disorders.
Good morning, everybody. So just to continue, what we're seeing with opioid prescribing practices is rooted in history, right? This just didn't come out of nowhere. And as many of you have familiarity with or experienced in your own career, at some point early on, opioids were part of a palliative care approach, right? When we didn't know what treatment options would be available. And over time, as treatment came out, people began having longer lengths of their life. We start to see kind of the more chronic side of it, right? People starting to develop chronic pain syndromes associated with their HIV illness. And I think there was a statistics of up to like 25 to 90% of people with HIV having chronic pain. And with that, about up to 50% of folks being prescribed a chronic opioid. And, as we move forward in time, we start to see that, people got to stay on their chronic opioids, this again, shifting to a more chronic care approach, and providers are now tasked with managing these opioids, which can be challenging at times. And sometimes we don't have the training to address this or manage complications when it comes to more situations with chronic opioids being a little more high risk in people with substance use and people with mental illness. And so sometimes the confidence wasn't there in being able to manage these. And, and also I think from like a compassion standpoint and wanting to engage people in care, I think a lot of providers were also worried that if I make changes with my opioid prescribing, is it going to change the way my patients engage in care? Are people going to be less engaged, or is their viral load going to go up? So that was another worry. I think that was coming up along as well. And so getting to where we are now, a lot of what we're working with is in this gray zone that we'll mention throughout this talk today. There's hardly ever any like clear answer to what is the right thing to do. You might have your one patient that got their hip replaced, got some opioids and then stops, and that's nice. But a lot of the times it's operating in that gray zone and not really knowing what the next step could be. And I think what we've learned is just trying to embrace in that gray zone. And so shifting over now into where we're at now, I think we saw kind of where the opioid epidemic led us, right? There was a urgency to reduce the number of opioids being prescribed, almost to the other side, where now it's really hard to get an opioid prescribed. I think a lot of these pill mills that initially were available closed down. It was harder to get prescriptions. Patients were left without prescriptions, and the CDC themselves actually put out guidelines to reduce to 90 MMEs. And I think, me having trained in this current time period, I think in my experience, it's been challenging to even start a prescription for opioids. So really swinging to the other end of the pendulum of having more to even start a prescription for that. Oh, there we go. And so, when we're thinking about opioids now, there's so much history, there's so much stress on the provider and wanting to do what's right for the patient. I think we need to just take a step back and think about, how we think about opioids, right? We're going to make the argument that it's not really different from, other high-risk medications. So, for example, we think about, pick your favorite anticoagulation medicine. There's the risk of bleeding if you take it, or you can develop a clot if you don't take it. And what is your goal for this? What is your goal for this medication? And, we're gonna monitor your INR. We're gonna provide guidance. If you start bleeding, please let us know so we can adjust your medication. So I would encourage to kind of think of opioids the same. There are risks, and for some patients, there are a lot of benefits that help them with their quality of life. And what are these risks and benefits? And just with like monitoring your warfarin, you're gonna monitor your opioid use with, urine tox, and side effects of your opioids as well, and providing anticipatory guidance, right? Like, if I notice that, you're needing early refills, if I'm noticing different opioids in your urine, this might be a case where we need to do more careful monitoring, or we need to think about how we prescribe your opioids. And always, as the clinical picture changes, we're always reevaluating, right? All right, so I'm just gonna pass it back over.
Okay, so with all of this in mind, when I started practice at Tom Waddell and inherited over 50 to 100 patients on controlled medications, I started to worry, right? It wasn't really clear what the policies were. It wasn't really clear what the guidelines were. And I knew that this is a patient who is telling me that this is beneficial, that this is why they come to their appointments. They're engaged in care in this way. And so there was this attempt to think more of, can we have a balance here where there's policy and guidelines that are balanced by the history of the patient in front of you? What is their quality of life? What is going to ensure that they are treated with dignity, that they trust you? And how can that both collectively help reduce their risk of harm and ensure there's ongoing partnership within that patient-provider relationship? And so within that work, I've helped with the controlled medication policies within the DPH. We've made some revisions in the last couple of years. We're now starting to include benzos and stimulants, and trying to be a little less opioid centric about how we're managing this, because we know there is quite a bit of overlap, and really moving towards a risk benefit approach and trying to share the burden, have easier access to support. You'll see little flashes of this policy throughout some of the slides, because I want to make sure you're all aware of what's new and available to you as another resource. So with that attempt of trying to weigh the rigor and the compassion and come up with something concrete for when I'm facing a patient who is really in that gray zone, I came up with these risk tiers. And so the way that they are designed is to think of a patient as a type of phenotype, right? So you have someone who is stable on their controlled medication, meaning that in this case, the benefit of them continuing their prescription is outweighing the risk. And you as the provider have that decision-making capacity, right? This isn't something that you necessarily need to talk over. You know the patient, you know what your perceived benefits are, and you know what the risks are. But what it breaks down to is, are they engaged in care? Are they coming to their appointments? Is their urine screen as expected? Are they doing the basic things that we expect? For example, signing and overviewing an agreement, an annual contract, and then are they able to control their substance use enough to provide a urine when asked for it? So again, this is sort of some detail of, they may be using drugs some of the time, but if they can control their drug use to be able to provide a urine and attend appointments as is expected, I would argue that they're stable, that you can keep going. In the slow down phase are folks who are missing some appointments. This is kind of an arbitrary number, but missing maybe 30% or so and not rescheduling. So there's times where you have to track them down to figure out, why didn't you come to your next appointment? And the urines are not always as expected. We'll go into a case, because I know there's a lot of known stimulant use in your population, but in this kind of general case, the urine is coming up not as expected. You didn't expect to see stimulants. You didn't expect to see these other opioids or benzos. Or it's, all negative, and you expect them to be taking their medication every day. Or they have an alcohol or cannabis or some other kind of legal drug use that is becoming risky, that's starting to interfere with their capacity to attend appointments and attend to their care. So that is sort of this at risk, let's slow down. The benefits and risks are a little bit less clear at this moment versus the stop taper. This is someone who we're now worried about harm. Their risks are outweighing their benefits. They're missing most of their appointments. They are unable to control their substance use. They're unable to manage this intensity of request increased monitoring, or they're showing evidence of harm. They're showing up in the ED with fentanyl overdose. They're, having these sort of numerous indications that something is wrong. They're falling, they're breaking bones, other types of traumas that we're worried about. So this is sort of the way to think about it. You'll see this often, and we're just going to pass this out. This is a handout for you guys to have. It includes the different tiers and then the monitoring strategy, as well as Zari's quadrants of pain. And then on the back, we break it down by the different scenarios that we'll be going through today with what is the policy and the risk tiers, and then some communication pearls. So hopefully that will be helpful. So again, if someone keeps going and it is stable in your mind, this is someone that you can give 3 months prescription, right? Obviously, you have to write each separate prescription, that you're able to see them and write prescriptions until their next appointment. You're comfortable with your continuation of the plan. This is someone who should not keep you up at night, right? We want more people who are stealing your sleep. This at-risk slow down, these are folks that we need to review the expectations again with the patient and increase the monitoring, that give them the opportunity to determine, are they able to keep going, or do we need to stop and taper? Can they show control of their substance use, or can they not? Can they handle a monthly appointment, or twice a month or weekly, whatever you determine as a provider, or can they not? And that's going to help you determine where they are in your mind. It's okay to hold patients in this at-risk state for as long as you like. You're the provider, you're the prescriber. And, trying to figure out and clearly articulate what comes next for the patient is really going to help guide those conversations and keep them coming to see you. So any questions about this before we dive into some clinical scenarios? Okay, so today we're going to go through 3.5 cases, 4 examples. The first we'll do is a request for opioids for pain. Then we'll go through an inherited patient on a controlled medication. Then we'll dive into a case of at-risk patient on a controlled medication. And then someone who perhaps needs tapering or transition to a medication for opioid use disorder. You'll see here that there's a lot of gray zone whenever you see this picture. We're intentionally making it difficult, right? We are always balancing the rigor and compassion in these cases, and there's no right or wrong, but hopefully these frameworks will help solidify your decision-making so you don't feel so alone, and that it's more easy to articulate the plan both to yourself and to the patient. Okay, all right, our animations are a little off, but first case. Hey, patient.
Hey, doctor. Yeah, my knees have just been hurting so much, and my roommate, they gave me one of their pills. I think it's oxycodone, and it really, really helped. Like, my pain is way better. Just curious, can I get some of that?
Wow, that oxycodone really helped you. I've got a lot of options for your pain. I've got gabapentin, I got lidocaine patches. Do you want me to do a knee injection today? I can do that for you. Is that something that you want to try?
That sounds nice and stuff, but I know the oxycodone works. So if you could just give me that would be great.
Oh, all right. Our first poll question. So how would you manage this request? Would you, one, say, I'm so sorry, we cannot do a new opioid prescription. This is the policy, no new prescriptions for non-cancer pain unless other modalities have failed. B, no new prescription. Pharmacy and insurances are not going to allow it, and it's going to be too hard for them to handle this. C, no new prescription, cite the data. D, provide a low-dose oxycodone. I'd rather him have a safe supply than having to get from his roommate or buy from the street. E, give a buprenorphine prescription. They're asking for an opioid. This is a safer opioid.
That's 1 second.
Okay,
So,
Okay, I'm seeing a nice split here. So citing the policy, that is a great place to start. Citing the data, a great place to be. No blaming the pharmacies, very nice of you. They are our partners in all of this. And then some people are, there's a good portion of people who think a buprenorphine prescription would be helpful. That's great. So citing the policy, this is a very useful thing to do and is intentionally there to support you as a provider, right? Our policy says no new starts unless other non-opioids fail, never at a first visit unless you can establish collateral that they've been on this prescription and that you've talked to them. So this is a helpful thing to have as your backbone, and policies work, right? Places like MXM and Street Medicine who have a no opioid policy, they just aren't having to deal with this at all. So this policy of saying no new opioids unless this, or no new opioids at a new appointment, is there to help support you. So you might say, you know, it's against our clinic policy to prescribe at this first appointment. Let's talk more about your pain. I've got a lot of good options to start. You know, no one shares this option, but pharmacies in this moment are creating a lot of barriers. As many of you know, a lot of Walgreens are closing. Those of you who do manage a lot of prescriptions know that they're not keeping in supply a lot of these, you know, morphine 15s, or, you know, next week it's oxycodones. And so there's a lot of delays and a lot of insurance issues. So you may also say, you know what, a lot has changed. Insurance and pharmacies don't support new prescriptions for chronic pain. In fact, the pharmacies don't even have enough in supply to fill those who are already on it, right? So that is something to offer the patient. I think at least letting them know that this is going to be a bit of a burden, more than it had been in the past. Citing the policy, also a great option, a popular one in the audience. So we know that the data is slim. There haven't been a lot of great studies, no randomized controlled trials around intermediate or long-term benefits of opioids versus placebo. We do see a slight short-term benefit for pain, function, and sleep quality for acute pain. However, when weighing the risks and benefits for long-term use for chronic pain, the risks continue to outweigh the benefits. And so this is a great article for all of you to also review. It's really comprehensive from the IDSA, what to do within your clinical practice of caring for folks with chronic pain. It has a lot of subtext in terms of people who are at end of life or people who've been on the prescription. And some conversation is say, you know, there's no study to support chronic opioids that improve your function long-term. You may say life is about how you spend your days, not when you take your next pill. How many of you, when trying to cite the data or have another conversation about why this prescription is not useful to them, they say, no, you don't know what it's like to be me. I get so much benefit when I take that oxycodone. I don't care what your data says. I know that opioids work for me. Heard that before? Yeah, and so that's where I think that this is another gray zone where we just have to realize that our data is limited and that patient experience, the patient perspective is something that we're going to be weighing all the time. Further, opioids help with emotional pain, and a lot of our patients have psychosocial vulnerabilities in which they don't want to feel, you know, there's unmet trauma, anxiety, depression, in which opioids can help numb for a bit, right? And so I'm not going to answer this question for you. This is why you have these tiers to help you, but there are times in which it's okay to trial an opioid. And I suggest that you start always in that at-risk category and phrase it as, this is a trial. These are all the reasons why I don't think this is going to work out, right? But let's consider. And so no one chose to start a low-dose oxycodone. That's good. And we want to just call out for someone who maybe wasn't feeling comfortable saying, we know that this has happened many a times in the past, which is what brought us to today with all these opioid prescriptions to manage, right? And knowing and understanding that there is really an argument for safe supply. There is also an argument in some cases for engagement in care, and knowing in some cases that there is an improvement in quality of life, or depending on who's in front of you, there may be some palliative benefit. Of course, we're weighing all of that with the known obvious risks that they'll become dependent on this opioid. They're at risk of developing a use disorder. They're at risk of dying from an overdose or misuse of the opioid or other opioids. Their pain will likely get worse, not better. And they're, at risk of other traumas and accidents. Want to also kind of reinforce that refusing a control medication is not refusing to manage the patient. And so that's more for us to know that you're doing enough and you're there for your patient as a good provider, even when you say no to that prescription. Touching the patient, doing an actual physical exam, looking and examining that pain can really, really be meaningful. And ensuring them, you know what, I've got 30 options instead of oxycodone. Let's talk about those things. And so this, as people have seen Soraya Azari's quadrants of pain before, this is on the back of your sheet, but this is just helpful to kind of reinforce, I do have tools here. They may not be the tools my patient is asking for, but you're not alone. You do have the knowledge and the access to various types of treatments. Buprenorphine prescription, this was also a popular option, and I think is a very valid one. Anyone in the audience want to share their experience of giving a buprenorphine prescription for pain? Yeah. And
I'll just say I had a mixed experience. I thought people would be excited, and I had one patient who said, I'm not an addict. Like, I know what this is for. Why are you giving this to me?
Yeah.
When I was sort of trying to say, oh, this is this great middle ground, and I was surprised by the blowback I got about perceptions of what it meant.
Matt?
I'll project. One thing that's been helpful is to counter that issue is to try alternative formulations. So, I often the patch. I found some patients didn't think the patch helped that much, and then we stopped it to try something else, and they were like, wait, my pain is worse. Actually, that was worse. So it can be helpful due to the trial to help them sort of see what it's like with and without. And then the buccal formulation can be helpful also. It's like different than the films and may not have the same connotations.
Great. Yeah, this is a resource from the VA. You can't see the whole slide in this room, but it is a helpful kind of breakdown of what is the MME. Are they opioid naive, or are you transitioning them from a full agonist to a buprenorphine? Patches are typically the first line for this. However, I will say in my own experience, similar to Matt, the patches are not terribly liked. A lot of times people feel like they're asleep the whole week and because it is, a full week of wearing the patch. And so I've seen more success with low doses. The buccal can be a little bit harder for the insurance to cover in my experience, but the sublingual, you can cut into tiny doses. There is the concern and is important anytime you're starting someone off on any opioid, including buprenorphine, is letting them know that they will become dependent on this prescription, and that they will need to take it every day. And if they don't, they may feel withdrawal. And so depending on the dose, but there is that expectation when you're using these smaller doses. You don't have to stop a full agonist. It's sort of like a micro dose start, right? For buprenorphine, so you can just slap it on. No need to have 8 hours or go into withdrawal before they start it. And then just know that in some cases, people who like to numb or are trying to stop stimulant use or reduce their alcohol use may escalate their buprenorphine use rather quickly. So just beware that what started off as like, oh, a little help for pain could quickly develop into a full-blown buprenorphine misuse disorder or misuse of the medications. And then you're stuck with someone who now has a very high tolerance for opioids when they didn't previously. So unfortunately, I've seen that a couple of times. All right, going into case 2. Okay, so now we're going to talk a little bit about inheriting a patient who's on a control medication. Let's say you're a new provider at Ward 86, and here's your panel. Here's 100 new patients for you from this retired provider. Guess what? 35 of them are on long-term opioids. this one, you're preparing for clinic and you see, okay, it's a 60-year-old living with HIV, undetectable viral load, methamphetamine use, history of severe skin soft tissue infection complicated by spinal osteo, who has been living with chronic pain on Oxy 30 4 times a day since 2010. You say, interesting that this one-liner says they're on opioids and they use speed, right? What's going on here? Let me try to figure it out in their note. Not so helpful, unfortunately. They have 3 urine toxins in the last 5 years. All are positive for amphetamine, and there's no documentation around their use in the provider's note. Certainly nothing around stimulant use being a red flag for continuation of their opioid prescription. You search addiction in your Epic and you find this small history of patients smoking methamphetamine out of a bubble pipe every morning to wake up. You're a little confused. Does this ever happen to any of you guys? Yes, maybe? Okay, and so you turn to Aisha and you're like, whoa, what is going on here? And someone else overhears and says, you know what, we did things a little differently back in the past. So how do you manage this new patient's controlled medication? What are sort of the things that you're weighing in terms of risk versus benefits? So the benefits, this is someone, let's say, who's attending their appointments, their viral load is undetectable. Great, this is in some cases all we want for our patients, right? And while we know the stimulant use is happening, there's no other substances in their urine screens. And from what we can tell, there's no history of overdose. This is beneficial, this is helpful. On the other hand, we know when someone is using stimulants, especially in today's world, there's often a risk of contamination of fentanyl, whether desired or undesired. And so they're at risk for potential morbidity, mortality related to that. And the lifestyle to have to, to continue to source their drugs and other things puts them at a higher risk. So how do you think about it? What stability tier is this patient? Slow down. Keep going. We'll just give it one more second. Anyone else? Okay, so really it is between this stable versus at risk. In this case, I might argue that this person is stable because the methamphetamine use is known, right? The urine screen is as expected. This is someone that we know uses methamphetamine. They're coming to appointments. We know they use methamphetamine. Their urine otherwise looks okay. In this case, we know there's active use, but there's no other kind of concerns about that. However, as someone who's taking this patient on as a new patient, this is your time as the provider to determine what tier is going to work for you as a prescriber. And so making sure those expectations are known. So in your mind, you might say, actually, I'm a little more worried. This is someone who's at risk. I'm not sure that their stimulant use is totally benign and not going to interfere with this plan. And so I'm going to let them know that I'm probably going to do a lot more urines than their prior prescriber. And I actually want to see them at least monthly for a while before I'm going to feel really comfortable putting them into this stable phase. So that's something for you to figure out. In the case where someone is stable, just know that going over a yearly agreement, at least a urine drug screen, although I would argue in many cases do it more often. We're going to just pass out a couple. So passing out just this controlled medication agreement, you'll see both Ward 86 current med agreement from, I think, last updated in 2018, and then the revised DPH. There's not a lot of copies. maybe pass them together,
Oh, pass them together.
just so they have one of Word 86 and one of the DPH policy. So live in Epic today with a few new modifications. We have a new controlled med agreement that is very pictorial and hopefully helpful for patients to understand what they're really up against and how we're using these risk tiers to help determine our decision making. Urine drug screens, I think this really is going to depend on the risk tier. So figuring out what risk tier they are is going to really help you know what you're going to do, when you need to see the next, when you need to get urines. And I would be really transparent about that frequency and make sure that you're consistent. All folks that you think are stable, determine how frequently you want to do their urine. About every 3 months, a little bit more often, a little bit less, just so that you're not introducing this bias of, oh, this very nice, stable patient, I'm gonna do it once a year. This behaviorally complicated, frustrating one, I'm gonna do every 3 months. And so making sure you're consistent is really helpful. Cures, you actually, I know it comes up on Epic every time, legally, just that first prescription every 4 months, and then considering other things, if they're on an opioid long-term, DEXA, testosterone. Know that monitoring dose, we're terrible at morphine equivalents in San Francisco. We're never going to meet that QI metric because our doses are so high. Thing to know for folks that you're inheriting on a controlled medication is you can't go up. I think that that's another helpful thing to say. Of course, there are times when you can go up if they have new cancer or new acute pain, but I think that has helped me with my patients is, oh, you know, this is when I do blame the pharmacies and the insurance. I can't go up, but guess what? I can switch you to a different opioid. And let's do some calculations based on how many MMEs you have on this oxycodone. Do you want to try a little bit of this, a little bit of that, and same MME in a way that is going to help with that cross tolerance with their opioid receptors and make them feel like they're part of the plan. They have some autonomy in controlling their medications. And of course, knowing there is increased risk for those who are on benzos and other things. So passing around also these patient handouts. And so you'll see a copy of the ones we have at Tom Waddell, and then also the ones at Word 86. I'm happy to share all of these, and this is that med agreement that is now live in Epic. So just really trying to take ownership of the fact that we too have a lot of expectations as the provider, and this is an agreement, meaning this is a way in which we're working together to ensure the patient on a controlled medication can safely continue on their medication. There's also a doc phrase that is usable for all of you. Just type in .controlled medRx. How many of you have had issues with pharmacies filling your controlled med because of documentation with good faith dispensing? No one's had to fill out a good faith dispensing form?
Does it for them.
Yeah.
Oh, you guys are so lucky. Well, in cases where that is happening, it takes a lot of time, but if you write a good note, they can just fax over your note. And so this is a helpful way to ensure that you're covering yourself, and your pharmacy support colleagues can quickly fax this over without having to try to figure out what your plan is based on poor documentation. This is the space to write that you know they use methamphetamine and the benefits outweigh the risks. Write it down, protect yourself, know what's going on. So when this patient shows up in the emergency department or you retire and you're passing this patient on to the new resident who's taking over, that they have an understanding of the history here. Okay.
Okay. All right, so I think y'all are warmed up, so we're gonna speed up the cases and increase the challenge. And we're at 9:10, so we got 20 minutes. So let's go for it. So next case, so this is a 55-year-old gentleman, history of HIV, also known methamphetamine use disorder, unclear psych history, really unstable housing, and on chronic pain that you inherited. And this is their prescription. They're on morphine 100 TID, extended release, and oxycodone 10 QID as well. And so just a little bit of background, I'll kind of speak through this just so we can get through the case. You know, their viral load is undetectable. They're on a stable regimen. They've been diagnosed with HIV since 2006. In terms of their question mark psychosis history, it's still unclear. Is this related to stimulant? Is this undiagnosed schizophrenia? In the past, I've had auditory hallucinations, but not really, but have been stable on mirtazapine and olanzapine. And then a little bit of their stimulant use history. They used crack cocaine for over 30 years, and most recently in 2015, started using methamphetamine, and really currently no longer using through IV, but using via insufflation, primarily during sex, and it helps with them with staying awake. And when you ask about opioid use, they share, I used to have an issue with heroin a long time ago, but it's not really a thing for me right now. And so, how did we get here? How does someone end up on 360 MMEs? So it all started back in 2014. There had a hand fracture that was complicated by a MRSA hardware infection, and at that time when they needed care given their unstable housing, they were started on this regimen. And so a couple years later, the patient continues on this regimen. You're seeing them now with their new PCP, but they're doing well. They're achieving all their goals. They're doing chores. They're mobilizing. No early refills. They're in the green zone, I would say here. But let's get into like what's happening a couple years later. In 2019. You're seeing your patient who, reports a little exacerbation of their current pain, and, one of their friends tried to help them out and said, hey, you want some heroin, and it found that it was really helpful for managing these exacerbations of their pain. Now they're using a little bit more consistently to help with that. So given that, your patient's telling you that they self-report that they're using heroin, in addition to help with exacerbations of their pain, would you continue prescribing opioids at this point? It's the time of the month for you to send their prescription, after their visit. What would you do? And I might need your help here, but yes. Yes. Okay, we did it. All right, so let's see. Yes, but with some increased monitoring, and let's talk a little bit about this heroin use, or no. This is worrying me, and I think we should switch over to buprenorphine instead. Neck and neck here. Anyone wanna, oh, there we go. Put in B as the winner. Okay, well, let's see how we would approach this, or one way to approach it, right? It's a gray zone. There's no right answers. So let's think through the different options. Choice A was yes, no change. Well, your patient is sharing with you, they are using on top of an opioid regimen, right? So using heroin, or as some of us know, like fentanyl as well, can increase their chance of overdose. So this is really a chance to kind of dive into their use and also discuss like risks, right? With concurrent use of prescribed opioids and unprescribed heroin or fentanyl. B, yes, but with increased monitoring. So, I gave you limited information, or we provided limited information about the heroin use on purpose, right? Because it's our role as providers to kind of really tap in and get more information about what their substance use is looking like, right? Intermittent substance use is not equal to a substance use disorder, and I think it's our role to really dive into that to see if there's a use disorder developing. Patient's relationship with, we need to explore that relationship, and can they control their use to keep their controlled prescription? Answer choice C, I would taper or discontinue. And I think we're providing kind of similar guidance. Intermittent use does not equal substance use disorder. And is there currently harm happening that would lend to their prescription being discontinued? Because I think another thing too is there is harm in completely discontinuing a prescription without support. There's many cases who I've met where patients, you know, had their prescription cut off by their provider all of a sudden and were left to use heroin in order to manage their pain. So that comes with its own risks as well. And then answer choice D, no, I would transition to buprenorphine instead. And I think that kind of circles back to like what we're caring for right now. Is this patient's pain uncontrolled, or are they developing a new substance use disorder that I would treat with buprenorphine? Or I can treat chronic pain with buprenorphine as well. And that would require a discussion with the patient. They would need to buy in, and you know, as you're doing this transition as well, they would need to be able to participate and be in a place to participate, right? And I think just if I hadn't brought this point home already, just to bring it home one more time, you know, this is like a different array of where we're at. There's substance use disorder, but also there is use sometimes that is not a use disorder, that is it doesn't get in the way of people's ability to do things. It doesn't get away to build the relationship. So really thinking about the spectrum. And so, in this case, I think what we felt, the area that we're at in terms of using the tiers as our guide is, you know, let's slow down a little bit. You know, your patient's reporting this to you. We haven't seen any evidence of harm, but let's see if they can control what's happening and come in to show that they can use control of their prescription. Let's monitor a little bit more frequently. Let's see if there's any additional red flags like sedation or emergency room visits that can put this patient at risk, and will, you know, increase their screening, will increase the frequency of visits and see how this goes. And I think we'll just kind of skip through this, but I think, you know, but could be an opportunity again to also reflect with the patient on the agreement that you all shared and signed together, right? You know, providing that anticipatory guidance, like, you know, I need to monitor you a little bit more frequently, and if I'm unable to, that could lead to me discontinuing your prescription or switching you over to a medication like buprenorphine if we're unable to. So really using your agreement as well to help you in this process. So what ended up happening, and this was a case that we're using as an example, but in this case, what ended up happening with the patient, I think the provider at the time decided to actually taper their patient at this point. They tapered their patient from a morphine of 100 to 75 twice a day. So a significant kind of reduction. And at the same time, the provider opted to continue with increased monitoring with urine toxicology. So I'm just gonna be really quick here. I guess one point before we go on, actually, no, I think we're just gonna skip this because I'm seeing it's 9:20. And I think we've kind of brought home that, you know, tapering and discontinuing medications doesn't come without its own risks. People can be at increased risk of overdose, mental health crises, you know, illicit substance use. So that also comes with its own risks. And so just going back to our patient, you know, they engage with providing urine toxicologies. This is their urine tox available. And I think one tip too is if something comes back positive, I think it's always good to send some confirmatory testing, especially with our stimulants. Stimulants often come back really falsely positive all the time as well. So in this case, the confirmatory testing showed morphine, hydromorphone, oxycodone, and oxymorphone. Quick review of heroin metabolism. So it's really metabolized to 6-MAM, and then it can be further metabolized to morphine and hydromorphone. So you can also Google this as well. Sometimes it's hard for me to remember. And just for you to know, the 6-MAM lasts about 12 to 24 hours in the urine as well, before metabolized to morphine and hydromorphone. So theoretically, the patient's confirmatory testing is consistent with being provided morphine and oxycodone, but doesn't necessarily rule out heroin use, just given that, the 6-MAM is metabolized to morphine. And so, just to go on with the case, I think the patient was able to demonstrate consistent use, provide their urine, and kind of went back to the stable, our green stables flag. And so now, a year later, we get testing for their urine toxicology screen. This is their urine tox, and you send the confirmatory testing. You send morphine, hydromorphone, codeine, and 6-MAM pops up along with oxycodone and oxymorphone. So at this point, would you continue prescribing opioids at this point? Okay. All right, we'll go a little fast just to give us some time at the end. Yes, no change but increased monitoring. No, I would taper, this is coming up again, and now I'm becoming more worried. This is a little bit more outside my comfort zone. No, I would transition to buprenorphine instead, maybe really revisiting that talk with the patient, just given now this is coming up for them, so. And I think, with each case kind of revisiting these points, right? I won't go into them again, but just really like, are we doing that history dive to talk about their use? Is this a use disorder developing? And does the patient maybe at a different point now where maybe buprenorphine might come up instead, either for a use disorder or for chronic pain? And can we monitor them to ensure safety? And so, so this is definitely for us, we were thinking, slow down. Let's get that information we need. Let's see if this pops up again on his future urines. Maybe let's control how many refills the patient's getting to shorter increments. And give us time to also dive in to see if he is developing a use disorder, or, even ask our addiction medicine colleagues too to weigh in and see how they can support us in navigating all of this, because you're not alone and we're here to help.
I just want to add, before that, sorry, just knowing that it is sometimes helpful to hold in this slowdown a little bit longer, even when there's active use, because once they're labeled as an opioid use disorder, once you transition into the buprenorphine, you can't really go back smoothly. And so it's a decision point. And so making sure the patient knows this is the time in which I need you to control your use and come in and adhere to this treatment plan. Otherwise, not only are we going to taper, we're going to discontinue, and bup is going to be the only medication that anyone's or methadone reasonably offer you in the future. And so making sure that's clear when this use is popping up before you're quickly determining a plan. Make sure the patient understands what's at risk is a critical piece. I think it's
Or actually, no. Okay, so now, next step, you find out that their patient unfortunately got evicted from their housing. They're staying with a friend, their methamphetamine use has increased substantially. They're not able to take their olanzapine as consistently. They're hearing more auditory hallucination. And you see on their chart that they actually were admitted or they were presented to the ED for unintentional fentanyl overdose. So what do you all think at this point?
You can shout it out.
And yeah, we can chat it out or put it in the chat as well.
We just have a few more minutes.
Okay, so we'll just
Okay.
go to the.
So at this point, this is when we enter the red, right? Where there's evidence of harm. An overdose happened. They, at this point, maybe they've been less consistent because their housing's unstable. They're deeper into their methamphetamine use. So we see a loss of control. They're not able to really consistently follow with us for a safe monitoring plan. So this is kind of with Dr. Abbs mentioning, letting the patient know we're kind of switching over into a use disorder and we need to, transition into, medications for a use disorder as well. That can be helpful. And it just is kind of reiterating that as well, and also referring to addiction medicine too, if that would be helpful in your support in this, because we're not alone. And so I think I won't spend too much time on this. I think you've all kind of been exposed to what we use to help us with diagnosing a use disorder. But we kind of separated into buckets, right? Loss of control. And what this might look like on someone with prescription opioids is they're running out early, they're borrowing, needing to use from friends, they're going to see different doctors for this prescription. They're kind of fixated on only opioids for management of their pain. Negative consequences, what that might look like in someone with the prescription opioid use is, they're not attending their appointments with you. They're not really addressing other issues of their health. Overdose, families and friends starting to express concerns, and issues with their relationships as well. And, once we transition into this point of opioid use disorder, we have all these amazing medications that can be helpful for your patient. And we're over here at Bridge Clinic too, to support your needs. And also a shout out to the National Clinician Consultation Center as well, which is a phone number you can call for help. And I think as we wrap up, I think one important thing when we're talking about pain as well is recognizing our personal bias and our history too, that's rooted in pain, our history and racism rooted in pain, right? And in thinking about our history, right, we think about how these different epidemics were approached. When we see the crack cocaine epidemic, that was approached with criminalization, right? When we see the more recent opioid epidemic with prescribed narcotics, we transitioned to thinking of addiction as a disease and focused on a public health approach to that. And we also hold space for patients who identify as Black, who have been historically discriminated against. And there's just been so many studies that shown that patients who identified as Black just did not get the same care as patients who identify as white. So holding that space for that and recognizing that is part of the interactions we're having with patients as well, that history. And I think as, hopefully this tool that we have is helpful in navigating these situations as well and thinking about the tiers. And then I think as we wrap up, I think that was it. Yeah. Thank you all. We're here for any questions, but I know we're like right at time. So thank you.
Thank you both so much for all those concrete tools. We are right at time, so we'll just give you a round of applause, but please, I will come down to ask.
Yeah.